so its incidence may be underestimated. This is partly due to the absence of a biomarker as an indicator of the common pathophysiological process. As a result, there is no gold standard diagnostic test, and the diagnosis remains to be formulated purely on clinical syndrome characteristics, as you can see in this flow chart of procedures to determine the diagnosis. In addition, the phenotypical variability of dystonia, other conditions mimicking dystonia, and the experience and expertise of the clinician contribute to the diagnostic accuracy. Overall, this approach is not reliable. Its specificity and sensitivity are not established, and the validity of clinical diagnosis without a biomarker cannot be assessed. Motivated by this clinical need and based on the current understanding of dystonia network pathophysiology, we recently developed a deep learning algorithm that uses structural brain images to diagnose dystonia based on automatic identification of neural alterations in these patients. The visualization of this biomarker showed that the algorithm correctly identified gray and white matter regions frequently reported to be microstructurally abnormal across the dystonia clinical spectrum. Using this microstructural network biomarker, the DystoniaNet algorithm achieved 98.8% accuracy in correctly classifying patients with laryngeal dystonia, cervical dystonia, and blepharospasm, and referring 3.5% of cases with an uncertain diagnosis for additional evaluations. Importantly, this diagnostic decision was delivered under 1 second, and thus compared to the current diagnostic procedures, which often require various evaluations during multiple visits to multiple specialists, DystoniaNet assisted diagnostic procedures may have an important impact on increasing the clinical accuracy. The final aspect of neuroimaging alterations in dystonia that may have widespread clinical implications relates to abnormal neurotransmission in this disorder. As a common feature across different forms of dystonia, dopaminergic alterations have been characterized by reduced availability of striatal D2, D3 receptors, increased availability of D1 receptors, and decreased dopamine release during motor task performance. These alterations appear to be somewhat topically distributed within the striatum, depending on the affected body region. Here you see the hand and larynx representations within the basal ganglia and involve not only posterior sensor motor striatum, but also anterior associative striatum. Similarly, reduced GABAergic neurotransmission within the dystonic network has been found in different forms of dystonia, and recently decreased vesicular acetylcholine transporter in striatum and cerebellum was reported in DYT1 dystonia. Together, these studies updated the basal ganglia cortical connectivity model, showing hyperactivity of the direct basal ganglia pathway, hypoactivity of the indirect pathway, disinhibition of the thalamus projecting to the sensory motor cortex. Bridging to the next talk, Dr. Pisani will discuss the clinical implications of abnormal neurotransmission in dystonia more, but I'd like to note a few points. Considering the current use of oral medications in dystonia patients, the use of most of these drugs is based on a trial and error approach. And when we examine the typical time course and cost of drug discovery and development, very few, namely 6 investigations, make up the list of ongoing clinical trials in dystonia. As defined by a recent white paper from the NIH workshop on research priorities in dystonia, one of the highest priorities is to target circuit level dysfunction with therapeutic intervention. Our current detailed understanding of abnormal neurotransmission already leads to developing a new pathophysiological animal models of disease for probing corrective modulation of neurotransmission. Moreover, neuroimaging knowledge of neurotransmission abnormalities may directly impact the development of novel or repurposing of existing drugs. In summary, dystonia is a neural network disorder with multifactorial pathophysiology, where network alterations include changes in function, structure, and neurotransmission. These alterations are both shared between dystonia forms and are form-specific, with more cortical abnormalities attributed to task-specific forms. Dystonia-specific neuroimaging changes in brain function and neurotransmission are being targeted for the development of new treatment strategies, while disorder-specific microstructural changes may likely serve as an objective biomarker for dystonia diagnosis. Thank you, and I look forward to receiving your questions and comments.
Okay, thank you. Thank you for your kind